Getting prepared to start our session. So we are in the last chapter of the book Cellular Immunology and Molecular Immunology, written by Abbas and colleagues. And the last chapter is primary and acquired immunodeficiencies. So we'll discuss overview of immunodeficiency, primary congenital immunodeficiency. Then we'll discuss about secondary acquired immunodeficiency. We are going to discuss immunodeficiency in viruses and acquired immunodeficiency syndrome. So that will be our overview, then we will go for summary. Let us start. Integrity of immune system is essential for defense against infectious organism and their toxic product, and therefore for the survival of all individuals. Defect in one or more component of immune system can lead to serious and often fatal disorder, which are collectively called immunodeficiency diseases. These diseases are broadly classified in two groups. The primary immunodeficiencies are genetically defects that result in an increased susceptibility to infections that is frequently manifested in infants and early childhood, but is sometimes first clinically detected later in life. A large number of individuals may inherit mutant genes that compromise the function of immune system. However, a small fraction inherited deleterious mutation that on their own have large enough effect on the development or function of immune system to be categorized as primary immunodeficiency disorder. Estimate of how to prevent primary immunodeficiency in the United States ranges from 1 to 12,000 to 1 in 10,000, although only a small proportion of these are affected severely enough for development of life-threatening complications. Secondary or acquired immunodeficiencies are not inherited diseases, but develop as consequences of malnutrition, disseminated cancers, treatment with the immunosuppressive drugs, or infection of cells of the immune system, mostly notable with the human immunodeficiency virus, HIV. The etiological agents of acquired immunodeficiency syndrome, AIDS. This chapter describes the major types of congenital and acquired immunodeficiency, with emphasis of their congenital and acquired immunodeficiencies, with an emphasis on their pathogenesis and development of immune system that are involved in this disorder. So let us start with overview of immunodeficiency diseases. Before beginning our discussion of individual diseases, it is important to summarize some general features of immunodeficiencies. The principal consequences of immunodeficiency is increasing susceptibility to infections. The nature of infection in a particular patient depends largely on component of immune system that is defected or defective. Deficient humoral immunity usually result in infections by encapsulated pus-forming bacteria and some viruses, where defect in cell-mediated lead to the infection by viruses and other intracellular microbes or other reactivation of latent infections. Combined deficiency in both humoral and cell-mediated immunity makes patients susceptible to infections by all classes of microorganisms. Immunodeficiency patients often present with infections by microbes that are commonly encountered but effectively eliminated by healthy persons. Such infections are said to be opportunistic. Defect in innate immunity can result in infection by different categories of microbes, depending on the pathway or depending on the cell type affected. In individual, in addition to clinically well-defined immunodeficiency diseases, there is growing evidence that adults with recurrent or severe infection may harbor mutation in genes that regulate immune function. So when you look carefully, you see that features of immunodeficiency affecting T and B lymphocytes. So we have features B deficiency and T cell deficiency. Susceptibility to infections. Mostly, if you have B cell deficiency, you get pathogenic bacteria, otitis, pneumonia, meningitis, osteomyelitis, enteric bacteria, and viruses. Some parasites also may happen. For T cell deficiency, you get pneumocystic girovec. Many viruses are typical, and mycobacteria and fungi. In terms of serum immunoglobulin, B cell deficiency causes a reduction in serum immunoglobulin, but T cell deficiency lead to normal or reduced. In delays type hypersensitivity, reaction to the common antigens, in B cell deficiency it is normal, but in T cell deficiency it is reduced. In terms of morphology of lymphoid tissue, when you speak of lymphoid tissue, a B cell deficiency causes absent or reduced follicular and germinocenters, B cell zones. But also T cells deficiency usually normal follicular may be reduced parafollicular cortical region T cell zones. So patients with the immunodeficiency are susceptible to certain types of cancers. Many of these cancers appear to be caused by oncogenic viruses such as Epstein-Barr viruses and human papillomavirus HPVs, and hence reflect a defective antiviral immunity, but the incidence of lymphoma and other cancer of the skin, stomach, and other organs with no known association with viral infection is also increased. In this chapter, we will first consider primary congenital immunodeficiency, including defect in component of innate immune system and defect in humoral and cell-mediated arms of the adaptive immune system. We will conclude with the discussion of secondary acquired immunodeficiency with emphasis on AIDS. Primary congenital immunodeficiency. A primary immunodeficiency monogenic disease caused by germline mutation in gene that regulate the development or function of the immune system. Although the earliest primary immunodeficiency disease disorder is in which the present genetic defect were identified were X-linked recessive disease, the majority of the primary immunodeficiency exhibit an autosomal recessive inheritance. Autosomal recessive alleles are often seen in consanguineous families where when the mutation is inherited from both parents. In other cases, especially in offspring of non-consanguineous marriage, one defect alleles of a specific gene is inherited from one parent, and different defective mutation in the same genes is inherited from other parent. Individuals with this kind of autosomal recessive inheritance pattern are referred as a compound heterozygotes. Sometimes a compound heterozygotes may include one or partially, or might include one or both partially defective hypomorphic alleles. Some primary immunodeficiencies are associated with autosomal dominant inheritance. These include gain function mutation, such as activating mutation in PIK3CD, encoding the hyperactive form of PI3 kinase delta. Other dominant inheritance mutation include loss of function mutation in one allele of genes that lead to impaired function but not complete loss of specific proteins. These may cause diseases because of haploinsufficiencies in mutation in CTLA4 and because of dominant negative effect whereby one defective gene product impair the activities of the protein products of normal allele. Occasionally, the causative mutations arises de novo in patient and is not present in either parents. These co-inherited germline mutation typically occur in germ cells of one of the parent or in fertilized egg. The expression of clinical presentation of the disease caused by same mutation may be variable. Multiple factors may contribute to the phenotypic variability, including co-inheritance of modifier genes, environmental factor, epigenetic modifications of genes that vary from one individual to another. However, in most cases, different phenotypic manifestation of the same mutation remain unexplained. So primary immunodeficiency disease generally come to light because of clinical history of repeated infection. Some diagnoses are quite easily made by measurement of serum immunoglobulin Ig level, flow cytometry of immune cells, and assessment of neutrophil function in vitro. However, more detailed investigations are often necessary to obtain an accurate diagnosis. Primary T cells immunodeficiencies are diagnosed by reduced number of peripheral blood T cells, low proliferative response of blood lymphocytes to polyclonal T cells activator such as the phytohemagglutinin, and deficient cutaneous delayed type hypersensitivity, reaction to ubiquitous microbial antigens such as Candida antigens. In the United States, it is now required that newborns be screened using an assay for T cell receptor excision cycle, that is called Cheriak. In blood cell, looking for DNA that is deleted during T cell receptor genes, the arrangement in developing T cells. The failure to detect these DNA cycles indicate an absence of T cell development. These assays used to diagnose severe combined immunodeficiencies, the immunodeficiency discussed later, immediately after birth, and allow a timely correction of defect by hematopoietic stem cell transplantation. Early diagnosis may also make gene therapy feasible before significant diseases have developed. Immunodeficiency may result from a defect in lymphocytes development or activation, or from defect in the effector mechanism of innate and adaptive immunity. Immunodeficient diseases are clinically and pathologically heterogeneous, in part because different diseases involve different components of immune systems. Abnormality in lymphocytes development may be caused by mutation in gene encoding receptor or other molecule involved in signaling, including enzymes, adapters, transport proteins, and transcription factors. These inherited defect and the corresponding target disruption in mice have been instructive in elucidating mechanism of lymphocyte development and functions. The availability of new, rapid, and efficient DNA sequencing technology has greatly increased our ability to identify specific genes that when mutated, confer susceptibility to infections or pathogens. One of the surprising lessons that is emerging from the analysis of immunodeficiency caused by single genes mutation is that many of them make individuals susceptible to a restricted set of infection. This observation suggests that in humans, distinct protective mechanisms are often critical for defense against specific pathogen, so that defect in any one mechanism makes an individual susceptible to only some infections. Paradoxically, certain immunodeficiencies are associated with the increased incidence of autoimmunity. Autoimmunity is generally seen in immunodeficiency in which there is incomplete loss of immune populations or function because of their hypomorphic mutations, possibly resulting in attenuation of some regulatory mechanisms. It is also possible that the persistence of infection associated with immunodeficiency causes innate immune activation and tissue injury, and promote the activation of autoreactive lymphocytes. In the following section, we will describe immunodeficiencies caused by inherited mutation in genes encoding a component of the innate immune system or in genes required for lymphocyte development and activation. Many of the known mutations are listed in the table, and only the most common and those that illustrate the importance of principle are described in the text. We conclude with a brief discussion of therapeutic strategy for these diseases. Defect in innate immunity. Innate immunity constitutes the first line of the defense against infectious organisms. Hence, congenital disorder of the component of innate immunity often result in recurrent infection. The mechanism of innate immunity was described in chapter 4. In this section of the chapter, we will discuss some example of congenital phagocyte disorder, natural killer cell deficiency, and genetic defect in toll-like receptor signaling and interleukin-12 interference pathway. Phagocyte defect generally result in infection of the skin and respiratory tract with bacteria and fungal, and later predominantly involving Aspergillus and Candida species. Deep-seated abscess and oral stomatitis are also common. Defect in toll-like receptor signaling are in type 1 interferon signaling may contribute to the recurrent pathogen infection and severe viral infections. Defect in interleukin-2 and in interleukin and in the interferon gamma pathway increases susceptibility to intracellular pathogen, particularly mycobacterium infection. Complement deficiencies are described in chapter 13. Complementary system are described in chapter 13. Defective microbiocidal activities of phagocytes, chronic granulomatous diseases. Chronic granulomatous diseases is caused by mutation in a component of phagocyte oxides, the PHOX enzyme complex. It is a rare disease estimated to affect approximately 1 in 200,000 individuals in the United States. Approximately 2/3 of the cases show an X-linked recessive pattern of inheritance, and the remainder are autosomal recessive. In the X-linked forms of disease, there is a mutation in the gene encoding the 95 kilodalton alpha subunit of cytochromes B558, an integral membrane protein also known as FOX91. Many different mutations in X-linked genes have been identified, and these mutations result in the defective production of superoxide anions, one of the several reactive oxygen species that constitute a major microcidal mechanism of phagocytes, especially neutrophil. Defective production of reactive oxygen species results in the failure to kill phagocyte microbes. Mutation in other component of FOX complement causes autosomal recessive forms of CGD. OGD, which is chronic granulomatous diseases, is characterized by recurrent infection with fungal and bacteria such as Staphylococcus, usually from early childhood. Invasive infection with the fungus Aspergillus is the leading cause of death. Many of the organisms that are particularly troublesome in patients with the chronic granulomatous diseases produce catalase, which destroy the microcidal hydrogen peroxide that may be produced by host cell from the residue reactive oxygen radical superoxides. Because the infections are not controlled by neutrophil, they stimulate chronic cell-mediated immune response, resulting in T-cell-mediated macrophage activation and also the formation of granulomatous composed of activated macrophages, which try to eliminate the microbes. This histological appearance is the basic key of the name of the disorder, which is chronic granulomatous disease. The disease was often fatal in the past, even with aggressive antibiotic therapy, but the prognosis has improved significantly now because of the earlier recognition and better control of infection. Cytokine interferon gamma enhance transcription of the gene encoding FOX91 and also stimulate the component of FOXC enzymes complex. Therefore, interferon gamma stimulate the production of superoxide by CGD neutrophil, especially in cases in which the coding portion of the FOX91 gene is intact, but its transcription is reduced. If neutrophil superoxide production is restored, at least 10% of the normal level, resistance to infection is greatly improved. In the United States, interferon gamma therapy is now used in some medical centers for treatment of X-linked chronic granulomatous diseases, CGD. Leukocyte adhesion deficiency. Leukocyte adhesion deficiencies are a group of autosomal recessive disorder caused by defect in leukocyte and endothelial adhesion molecules. These diseases are characterized by failure of leukocyte, particularly neutrophil, recruitment to site of infection, resulting in severe periodontitis and other recurrent bacteria infection starting early in life. An inability to make pass. Different types of leukocyte adhesion deficiencies are caused by mutation in different genes. So we have the congenital disorder of innate immunity here around. I'll read them and you will see the comparison. So congenital disorder of innate immunity. The disease is chronic granulomatous disease. Functional deficiency here, the defective production of reactive oxygen species by phagocyte, recurrent bacteria, and fungal infections. Mechanism of defect, mutation in gene encoding proteins for phagocyte oxidase complex, which is FOX91, cytochrome B558 alpha subunity is mutated in X-linked forms. Then we have leukocyte adhesion deficiency type 1. This the functional deficiency here, the defective leukocytes adhesion to endothelial cells and migration into tissue linked to decreased or absence of expression of beta-2 integrin, recurrent bacteria, and fungal infections. Here, the mechanism of defect is mutation in gene encoding the beta chains CD18 of beta-2 integrins. Then we have disease called leukocytes adhesion deficiency type 2. Here, the main functional deficiency is defective leukocytes rolling and migration into tissue linked to this decreased or absent expression of leukocyte ligands for endothelial E and P selectin, causing failure of leukocyte migration into tissue. Recurrent bacteria and fungal diseases are the common ones for this leukocyte adhesion deficiency type 2. And mechanism of defect, mutation in gene encoding GDP, Foucault's transporter 1, required for the transport of Foucault's into the Golgi and into incorporation into ciliary Lewis X, the ligand for selectin. Another defect disease that we are having as congenital is leukocyte adhesion deficiency type 3. Then here, the function of deficiency is defective leukocyte adhesion and migration into tissue linked to defective chemokine stimulated integrin activations. So what happened? The mechanism is mutation in the gene encoding kindolin 3 cytoskeletal protein linked to integrin activations. Then we have Cheriak Higash syndrome. Cheriak Higash syndrome, the functional deficiency is the defective vesicle fusion and lysosomal function in neutrophil, macrophage, dendritic cell, and natural killer cell, cytotoxic cell, and also other cells, which are many other cell types, recurrent infection, pathogenic bacteria, they happen from this disease. So what happened? The mechanism of defect, The mutation in list lead to the defect in secretory granules, exocytosis, and lysosomal function. Then you have natural killer cell deficiency. This actually functional deficiency is reduced or absent natural killer cells. What happened? The mechanism of action is mutation in gene encoding GATA2 transcription factor and in the genes encoding the MCM4 DNA helicase. Then we have toll-like receptor signaling defects. Here, what happened actually functional deficiency. The functional deficiency is recurrent infection caused by defect in toll-like receptor and CD40 signaling and defect in type 1 interferon production. So what is the mechanism of action, how it happened? Mutation in toll-like receptor 3, TRIF, TBKI1, NEMO, UNC93B, MD88, 1 kappa beta alpha, and IRAK4 compromise nuclear factor kappa beta activation downstream of toll-like receptor. Another thing is another disease is Mendelian susceptibility to mycobacterial disease. Here, severe disease caused by non-tuberculous environmental mycobacteria, BCG, Salmonella, and other intracellular bacteria. So what happened? The mechanism of action, here there is a mutation of interleukin 12, P40 interleukin 12, RB, IFNGR1, IFNGR2, STAT1, NEMO, and ICG12. So those are the summary of the disease that are happening. So let us continue with explanation of what we have read. Leukocytes, adhesion deficiency type 1, LAD1, is the rare autosomal recessive disorder characterized by recurrent bacteria and fungal infections and impaired wound healing. The umbilical cord separation, which normally occur as the consequence of inflammation and neutrophil infiltration, is delayed, and the leukocytosis is common. In these patients, most adhesion-dependent function of leukocytes are defective, including adhesion to endothelial, neutrophil aggregations, and chemotaxis, phagocytosis, and cytotoxicity mediated by neutrophils, natural killer cell, and T lymphocyte. The molecule basis of the defect is absence of or reduced expression of the beta integrins, heterodimer of CD18 and the CD11 family of glycoproteins. As a result of the mutation in CD18 genes, the beta 2 integrin include leukocyte functioning associated antigen 1, leukocyte function associated antigen 1, LFA1, or CD11 and CD11A and CD8. MAC1 associated antigen, MAC1, CD12, CD12B, CD18. And also P150 95, which is CD11C, CD18. These proteins participate in adhesion of leukocyte to other cells, notably endothelial cells, and the binding of T lymphocytes to antigen-presenting cell, APC. Leukocyte adhesion deficiency type 2, LAD2, is another rare disorder in which, as in LAD1, children present with recurrent infections and leukocytes, but they also exhibit severe developmental abnormalities. LAD2 results from an absence of CR-Lewis X, the tetrasaccharide carbohydrate ligand on neutrophils and other leukocytes that is required for binding of these cells E-selectin and P-selectin in cytokine activation endothelials. This defect is caused by mutation in guanosine diphosphate, GDP, fucose transporter, responsible for the transport of fucose into the Golgi, resulting in an inability to synthesize Cytosyl Lewis X. The absence of Cytosyl Lewis X results in defective attachment of leukocyte to endotheliums and absence of leukocyte rolling, and therefore defective recruitment of leukocytes to the site of infection. This abnormality is in fucosyl lesions seen in LAD2 also contribute to the Bombay blood group phenotype, which is the lack of fucosylate He glycans that form the core of ABO blood group antigens, because LAD2 has many non-immunological manifestations related to the defective fucose metabolism. It is also called the congenital disorder of glycosylation, CDG. Leukocytization deficiency type 3, LAD3. Patients present clinically with repeated bacterial infection and delayed umbilical cord separation as in LAD1, but also have a life-threatening bleeding disorder that required blood transfusion because of defective platelet aggregations, even though blood platelets counts are normal. This deficiency is caused by defect in inside-out signaling pathway that are mediated that mediate the chemokines induced integrin activation that is required for leukocyte to bind firmly to endothelium. See chapter 3. For the platelet to aggregate, in a subset of patients, it is caused by mutation in gene encoding kindlings 3, a protein that binds to cytoplasmic tail of some integrin and is involved in signaling. So leukocytizations, actually there are 3 types. We have defect in natural killer cells and phagocytes. Rare patients lacks natural killer cells because of autosomal dominant mutation in the gene encoding for GATA2 transcription factor. Loss of GATA2 activity results in diminished precursor population in the bone marrow and result in loss of natural killer cells, as well as decrease in the monocyte dendritic cells and B cells. Autosomal recessive mutation in MCM4 mean chromosomes maintenance complex component 4, a DNA helcase also result in the loss of natural killer cells, accompanied by adrenal insufficiency and growth retardation. Autosomal recessive mutation affecting CD16, FC gamma RIIA, and an FC receptor that mediate antibody-dependent cell-mediated cytotoxicity, ADCC, result in the loss of natural killer cell functions that goes beyond the loss of ADCC activities. Why CD16 is required broadly for natural killer cell function is unclear. Patients present with severe infection with viruses, mainly of the herpes viruses and papilloma virus families. Cheriak Higash syndrome is the rare autosomal recessive disorder characterized by recurrent infection by pathogenic bacteria, partially oculocutaneous albinism, and infiltration of various organs by non-neoplastic lymphocytes. The neutrophil, monocyte, and lymphocytes of these patients contain a giant lysosomes. This disease is caused by a mutation in gene encoding for protein lysit, LYST, which regulate the intracellular trafficking of lysosomes. The mutation results in the defective phagosome lysosomes fusion in neutrophil and macrophage, causing reduced resistance to infection. Defective melanosomes formation in melanocyte causing albinism, and lysosomal abnormality in cells of the nervous system causing nerve defect, and platelet leading to bleeding disorder. Giant lysosomes form in neutrophil during the maturation of these cells from myeloid precursor. Some of these neutrophil precursors die prematurely, resulting in a moderate leukopenia. Surviving neutrophil may contain reduced level of lysosomal enzymes that are normally functioning in microbial killings. These cells are also defective in chemotaxis and phagocytosis, further contributing to their deficiency microcidal activity. Natural killer cell function in this patient is impaired, probably because of an abnormality in cytoplasmic granules that stores the proteins mediating cytotoxicity. The severity of the defect in cytotoxic T cells lymphocytes function is variable among patients. A mouse strain called the Beige mouse carries a mutation in mouse homologue of genes encoding for LIST and is characterized by deficient natural killer cells function and giant lysosomal in leukocytes. Inherited defects in toll-like receptor pathway are nuclear factor kappa beta signaling and type 1 interferons. Inherited defects in toll-like receptor-induced responses are rare and tend to cause fairly circumscribed clinical phenotypes. Toll-like receptor 3 mutation result in herpes simplex encephalitis. Almost all viruses, including DNA viruses such as herpes viruses, generate double-stranded RNA transcript, and these are recognized by toll-like receptor 3. The major signaling pathway downstream of the most toll-like receptor and the major signaling pathway downstream of the most toll-like receptor and of the interleukin-1 receptor involve the MD88 adapter and the IRAK4 and IRAK1 kinases. And this pathway result in the nuclear factor kappa beta dependent induction of pro-inflammatory cytokines. Individual with mutation in MID88 and IRAK4 have severe invasive bacterial infection early in life, especially pneumococcal pneumonia. Later in life, infection tend to be less severe. Toll-like receptor 3 signaling uses the tariff adapter proteins instead of MID88 and TBK1, a serine threonine kinase that function downstream of tariff to activate IRF3 and nuclear factor kappa beta by a non-conical pathway. Autosomal recessive mutation in tariff and an autosomal dominant mutation affecting the TARIF3 E3 ligase also result in susceptibility to herpes simplex encephalitis. A similar phenotype is observed with the autosomal dominant mutation in gene encoding for TBK1. Toll-like receptor 3, 7, 8, and 9 recognize nucleic acid are located in endosomal and require protein called UNC93B, uncoordinated 93B, for their function. Uncoordinated 93B is an endoplasmic reticulum membrane protein that interact with endosomal toll-like receptor when they are synthesized in the endoplasmic reticulum and help deliver the toll-like receptor to endosomes. The uncoordinated 93B protein is also critical for signaling of nucleic acid specific toll-like receptor. Homozygous mutation in uncoordinated 93B result in reduced type 1 interferon generation and increases susceptibility to herpes simplex encephalitis. Signaling downstream of the endosomal toll-like receptor result in a synthesis and secretion of type 1 interferons, which bind to type 1 interferon receptor and react and activate the STAT signal transducer and activation of transcription 1. Transcription factor in some patients, loss of function of STAT mutation are linked to severe viral infections, notably herpes simplex encephalitis. The finding that mutation in toll-like receptor 3 itself or the finding that mutation in toll-like receptor itself or in gene that affect toll-like receptor location and signaling all result in susceptibility to herpes simplex encephalitis indicate that type 1 interferon production downstream of toll-like receptor activation is crucial in defensive against this infection in central nervous system. Interestingly, patients with severe COVID-19, but not with less severe disease, frequently have mutation in toll-like receptor 3 and downstream genes linked to type 1 interferon production. Some immunodeficiencies are caused by defects that specifically affect nuclear factor kappa B activation. Point mutation in IKK inhibitor of KB kinase gamma, also known as NEMO, NF-KB essential modulator, which encode for a component of 1 kappa beta, I kappa beta or 1 kappa beta kinase complex that is required for NFK beta activation, contribute to the X-linked recessive disease known as anhidrotic ecdemodysplasia with the immunodeficiency ED. In this disorder, differentiation of ecdemo-derived structure is abnormal and immune function is impaired in the number of ways. Response to toll-like receptor signal as well as CD40 signal are compromised. These patients suffer from infections with the encapsulated pathogenic bacteria as well as with intracellular bacteria pathogen, including mycobacteria viruses, fungal, such as Pneumocystis jirovecii. See the discussion later in the section of hyper Igm syndrome. Defect in interleukin 12 interferon gamma pathway. Interleukin 12 is secreted by dendritic cell and macrophage, and the interleukin 12 receptor signaling stimulate the synthesis of interferon gamma by helper T cells, cytotoxic T cells, and natural killer cells. Mutation in gene encoding interleukin 12 P40, the interleukin 12 RB beta 1 chains and both chains of interferon receptor, as well as some mutation in STAT and IKK gamma stroke NEMO result in susceptibility to environmental mycobacterium species, often called the atypical mycobacteria, such as Mycobacterium avium, Mycobacterium kansasi, and Mycobacterium fortuitum. The term Mendelian susceptibility to mycobacterium disease is used for these disorders in which patients are predisposed to severe disease caused by weakly virulent mycobacterium that do not cause disease in healthy individuals, as well as other intercellular pathogens, including Salmonella and various other bacteria, fungal, and viral species. Defect in splenic development. Splenic development may fail because of an autosomal dominant and sometimes sporadic condition called the isolated congenital asplenia. In these patients, heterozygous missense mutation have been found in NBX2,5, which encoded for a transcription factor. Asplenia is also may be caused by mutation in gene controlling left-right laterality, which also affect other organs. Congenital asplenia patients frequently suffer from severe infection with encapsulated bacteria, especially Streptococcus pneumoniae. Severe combined immunodeficiency. Immunodeficiencies that affect both humoral and cell-mediated immunity are called severe combined immunodeficiency, SCID. SCID is usually resulting from impaired T lymphocytes development resulting in a defective cell-mediated immunity, with or without defective cell in B cell maturation. When there is no block in B development, the defect in humoral immunity is due to absence of T cell help. SCID patients suffer from severe infection that may be life-threatening, including pneumonia, meningitis, and bacteria. Among the most dangerous organism in the context of SCID is intracellular fungus called P. girovec, which can cause severe pneumonia in SCID patients. Many viruses causes serious diseases in patients with SCID. Chickenpox, varicella infection usually limited to skin and mucous membrane in immunological normal children and typically resolve in days. But in patients with SCID, it can progress to involve the lungs, liver, and brain. Cytomegalovirus, which is present as a latent infection in most people, may be easily transmitted, often from mother to kid patients to their offspring, and cause fetal pneumonia in newborns. Children with SCID commonly develop a gastrointestinal infection caused mostly by rotavirus, CMV, and protozoa Cryptosporidium and Giardia lamblia, leading to persistent diarrhea and malabsorption. Children with SCID may also develop infection caused by live attenuated vaccines, which are not harmful in children who are have normal immunity. Vaccine for chickenpox, measles, mumps, rubella, and rotavirus are live vaccines, and children with SCID can develop various infections from these vaccines. Some SCID patients develop a chronic skin rashes that is often mistaken for infections. The rashes is actually caused by graft versus host reaction, in which maternal T cells enter the fetus but are not rejected because of fetus lack a competent immune system and react against paternal allogenic antigen in the baby's tissue. Mutation in general in genes involves different steps in lymphocyte development and may cause SCID. You'll see it in figure 21, 1. The process of T and B lymphocyte maturation from hematopoietic stem cells to functional, competent, mature lymphocyte involve proliferation of lymphocyte, progenitor, rearrangement of antigen receptor genes, and selection of cells with useful specificities. Seen in chapter 8. Defect in many of these steps have been described in different forms of SCID, including defect in thymus development, purine metabolism, and cytokine signaling. Approximately 50% of SCIDs are autosomal recessive. The rest are X-linked. X-linked SCID. X-linked SCIDs is caused by a mutation in gene encoding for common gamma C chains shared by the receptor for many cytokines, including interleukin-2, interleukin-4, interleukin-7, interleukin-9, interleukin-15, interleukin-21. X-linked SCID characterized by impaired maturation of T cell and natural killer cells and greatly reduced number of mature T cells and natural cells, but the number of B cell is usually normal or increased. This disease is the result of inability of lymphopoietic stem cells, lymphopoietic cytokines interleukin-7, whose receptor uses the gamma C chains for signaling to stimulate growth of immature thermocytes. Humoral immunodeficiency in this disease is due to lack of T cell help for antibody productions. The receptor for interleukin-15, which is required for natural killer cells development, also uses the gamma C signaling chain, and the failure of interleukin-15 signaling accounting for deficiency of natural killer cells. Heterozygous females are usually a phenotypically normal carrier, whereas male who inherit the abnormal X chromosomes manifest the disease. Because developing cells in family randomly inactivate one of the two X chromosomes, the normal allele encoding a functional gamma C protein will not be expressed in half the lymphocyte precursor in female carrier. These cells will fail to mature, and consequently all the mature lymphocytes in female carrier will have inactivated the same X chromosomes carrying a mutant allele. In contrast, half of all non-lymphoid cells will have inactivated X chromosomes and half the others. A comparison of X chromosomes inactivation in lymphocyte versus non-lymphoid cell is sometimes used to identify carrier of mutant allele. Non-random use of X chromosome in mature lymphocyte is also characteristic of female carrier of other mutated X-linked genes that affect lymphocytes development and discussed later. Severe combined immunodeficiency. So we have table 21.3, and here we are speaking of severe combined immunodeficiency. A summary, we have the disease, functional deficiency, and mechanism of defect. So we have defective pre-T cell receptor checkpoint. This functional deficiency causes decreased T cells, normal or reduced B cell, and reduced Ig. The mechanism here, mutation in CD45, CD3D, CD3E, ORAX2, crack channel component, and STEM1. The George syndrome, it has a characteristic of decreased T cells, normal B cells, normal or reduced serum IgG. So here there is deletion of 22q11 deletions, T-box ones. So a transcription factor mutation. FOXN1 deficiency, this is thermic aplasia with defective T cell development. Here recessive mutation in FOX1s. We have toll-like receptor alpha chains deficiency leads to no alpha beta T cells, gamma delta T cells normal, gamma delta T cell normal, recurrently it causes recurrent infection autoimmunity. So when we go back with the function, it is autosomal recessive deletion in C regions of T cell receptor alpha chains. Defective T cells, thermic egress, and defective T cell signaling. Marked reduction in all peripheral T cells will happen, mutation of RORE and the MST1. Selective loss of CD4 T cells and defective T cell signaling. It causes a decreased CD4 T cells, mutation in LCK and UMC11-9. Bayer lymphocyte syndrome. Here the defective is MSC class 2, expression and deficiency in CD4 T cells, defective cellular mediated immunity, and T-dependent humoral immune response. Defect in transcription factor regulating MSC class 2 genes, expression including ACETA, RF, RF5, and the RF XUp. MSC class 1 deficiency. Here will be decreased the MSC class 1 level, reduce the CD8 T cells caused by mutation in TAP1, TAP2, and TAPACIN. Reticular dysgenesis. Here leads to the decreased T cells and B cell and myeloid cells. Defective in nucleotide sulfate pathway. ADA deficiency, a progressive decrease in T cells, B cell, and the natural killer cell reduce the Ig. Here, mutation in ADA genes leading to accumulation of toxic metabolic lymphocytes. PNP deficiency lead to progressive decrease in T cells, B cell, and natural killer cell, reduce serum IgG. Then mutation in the PNP gene leading to accumulation of toxic metabolites in lymphocytes. Defect in cytokine signaling. X-linked SCID, marked decrease in T cells, normal or increased B cells, reduced serum Ig, cytokine receptor, common gamma chains mutation, defective T cell development because of absence of interleukin-7 derived signal. Autosomal recessive SCID, marked decrease in T cells, normal, or increase the B cells, reduce the serum IgG. So here, what happened is mutation in interleukin-7 RA, JAK3, and JAK3, yes. Defective in VDJ recombinants. RAG1 and RAG2 deficiency lead to the decreased T and B cells, reduce the serum Ig, absence of or deficiency of T and B cells. And here the problem is cleavage of defect during VDJ recombination, mutation in RAG1 and RAG2. Double-stranded DNA break repair defect. This one decreases the T and B cell, reduces the serum Ig, absence of deficiency of T cells, and absence or deficiency of T cells and B cells. So here again, failure to resolve hairpins during VDJ recombinant mutation, Artemis DNA peaks, and the Genoronus League 4 NBS1 MRE11 ATM. So those are things that are just severe combined immunodeficiency. You lack both, most of them you lack both of T and B cell, from defective T cell receptor, the George Fox deficiency, TSR deficiency. So all these ones, they can cause problem. So we have the diagram, of which is better you have time yourself to go through. That immunodeficiency caused by defect in B and T cell maturation, primary immunodeficiency caused by genetic defect in lymphocyte maturations are shown. Gene encoding the listed proteins are mutated in immunodeficiency patients. So there are a lot of genes that encodes. So from the hematopoietic stem cells, so defect in T and B cell development can happen. We call the SCID itself. So it can happen in many things. Yeah, it's good you have time to go and read the topic itself. Other deficiencies or other forms of SCID caused by defects in nucleotide metabolism. The most cause of autosomal recessive SCID is deficiency of enzyme called adenosine deaminase, ADA. Due to mutation in the ADA genes, ADA function in the salvage pathway of purine synthesis and catalyze reversible deamination of adenosines and 2-deoxoadenosine to ionosine and 2-deoxoionosine respectively. Deficiency of enzyme lead to the accumulation of deoxoadenosines and its precursor, AC-adenosyl homocysteine and the deoxoadenosines triphosphate. These byproducts have many toxic effects, including inhibition of DNA synthesis. Although ADA is present in most cells, developing lymphocytes are less efficient than most other cell types at degrading DATP into 2-deoxoadenosine, and therefore lymphocytes maturation is particularly sensitive to ADA deficiency. Other features of the disease can include deafness, costochondral abnormality, liver damage, and behavioral problems. ADA deficiencies lead to the reduced number of B and T cells. Lymphocyte cells number are usually normal at birth, but fall with the precipitous during the first year of life. Few patients may have nearly normal number of T cells, but these cells do not proliferate in response to antigenic stimulation. A rare autosomal recessive from a SCID is due to deficiency of purine nucleotide phosphatase, PNP, an enzyme that is also involved in purine metabolism or catabolism. PNP catalyzes the conversion of ionosine into hypoxanthine, and the guanosine to guanine, and deficiency of PNP lead to the accumulation of deoxyguanosines and deoxyguanosine triphosphate with the toxic effect on immune lymphocyte, mainly T cells. Autoimmune hemolytic anemia and progressive neurologic deterioration are also a feature of this disorder. A particular severe form of SCID is seen in disease called reticular dysgenesis. This rare disorder is characterized by the absence of T and B lymphocytes and most myeloid cells, including granulocyte, and is due to a defect in development of lymphocytes and the myeloid progenitor. This is an autosomal recessive disease due to mutation in adenylyl kinase 2CK genes, and the AK2 protein regulates the level of adenosine diphosphate, and in absence of AK2, there is an increased apoptosis of lymphoid and myeloid precursor. Sorry. Autosomal recessive mutation in cytokine signaling component. Some patients with a disease clinically identical to X-linked SCID shows an autosomal recessive inheritance. These patients have mutation affecting the interleukin-7 receptor alpha chains or the JAK3 kinase, which associated with the gamma C chain and is required for signaling by this receptor. Patients with the mutation in the genes encoding interleukin-7 receptor alpha chains have defect in T cell development but exhibit normal natural killer cell development because interleukin-15 signaling is unaffected and they have normal number of B cells. Severe combined immunodeficiency caused by defect in VDJ, recombination, and T cell receptor checkpoint signaling. Absence of VDJ recombinations leads to the failure to express a pre-T cells receptor and pre-B cells receptor, BCR, and block in T and B cell development. Mutation in the RAG1 or RAG2 genes, which encode protein that mediate and cleavage step during VDJ recombination, or the Artemis genes, which encode the endonuclease that resolve the coding end hairpins during VDJ recombination, or result in the failure of VDJ recombinations. These diseases are rare, but they account for a large percentage of autosomal recessive forms of SCID. The function of these proteins are discussed in Chapter 8 in the children with this mutation, and in children with this mutation, B and T lymphocytes are absent, and immunity is severely compromised. Mutation in genes encoding protein involved in double-stranded break repair and non-homologous end joins of DNA also lead to the SCID because of defective VDJ recombinations. These include gene encoding for catalytic subunit of the DNA-dependent protein kinase, DNA-PIC, and DNA ligase 4. Genetic defect in this end joining process also result in increased cellular sensitivity to radiation and other result into radiation and can result in other manifestations such as microcephaly, facial dysmorphism, and defective tooth development. Although most autosomal recessive form of SCID are linked to mutation in other RAG1, RAG2 atamins, other forms of this syndrome are caused by mutation in the gene encoding the CD45 phosphate which is a positive regulator of CRC family kinase, this such as FYN, LCK, and LYN. And a mutation in the CD3 delta or L epsilon chains or in the CD associated zeta chains. These mutations contribute to the defective pre-T cell receptor signaling and result in the block in alpha beta T cells development. A specific defect in alpha beta T cell development and clinical presentation that involve recurrent viral infection is caused by homozygous mutation in genes encoding T cell receptor alpha chains. T cell receptor alpha constant region affecting individual present with increased susceptibility to infection. Affected individual present with increased susceptibility to infection, including chronic varicella zoster, Epstein-Barr viruses infection, as well as autoimmune and the features of atopy. Clinical features including eosinophilia, vitiligo, eczema, alopecia areata, autoimmune hemolytic anemia, and the absence and the presence of other autoimmune autoantibodies. The immune dysregulation may reflect the absence of regulation T cells. The only T cells present in infants with this disease are gamma delta T cells. Autosomal recessive mutation in LACs, which encode tyrosine kinase required for T cell receptor and T cell receptor signaling, also can cause a form of SCID with T cell deficiency and lack of regulatory T cells, recurrent infection, and the feature of immune dysregulation. Hypomorphic mutation that only partially reduce function in RAG gene and in artemethin are the cause of disorder called the Omen Syndrome, characterized by reduced generation of T and B cells, immunodeficiency, and autoimmune and allergic manifestation. Omen syndrome is phenotypically very different from SCID that is caused by more severe mutation in these very same genes. Because the immunodeficiency in this syndrome coexist with the exaggerated immune activation and autoimmune, although the mechanism underlying the excessive immune activation in this disease is unclear, it may be result of an abnormality of low ratio regulatory T cells to effector T cells, or in case of decreased VDJ recombinant defect receptor editing in mature B cells. SCID caused by complete loss of RAG function and Omen syndrome caused by partial loss illustrate how the severity of defect in some genes can greatly influence the resulting phenotype. The George syndrome and other forms of SCID due to defective thymus epithelial development. Complete or partial failure of development of thymic enlarge can lead to the defective T cell maturation. The most common defect in the thymic development causing SCID is seen in children with the George syndrome. This selective T deficiency results from defective development of thymic and the parathyroid glands, as well as other structure that arise from the third and fourth pharyngeal pouches during fetal life. Disease is characterized by immunodeficiency because of hyperplasia or agenesis of thymus leading to deficiency of T cell maturation, abnormal calcium homeostasis, and the muscle twitching. Tetan due to absence of parathyroid gland, abnormal development of great vessels, and facial deformities. Different patients may show a varying degree of this abnormality. The disease is caused most often frequently by a deletion of chromosomal region 22q11. A mouse line that has a similar defective thymic development carries a mutation in gene encoding transcription factor T-box, which lies with the same chromosomal regions. This suggests that Immunodeficiency associated with Igm syndrome can be explained at least in part by deletion of XTBX1. In this syndrome, peripheral T cells are absent or greatly reduced in number, and the cells do not respond to polyclonal T cell activation or mixed with the leukocyte reactions. Antibody levels are usually normal, but may be reduced in severe affecting patients, as in the other severe T cell deficiency, patients are susceptible to mycobacterium, viral, fungal infections. The immunodeficiency associated with Igm syndrome can be corrected by phytothermic treatment, phytothermic transplantation, or by bone marrow transplantation. However, such treatment is usually not necessary because T cells function tend to improve with age in large fraction of the patient and is often normal by 5 years. This improvement is probably because of some residue thermic tissues or because of yet undefined thermic sites assume the function of T cell maturation. It's also possible that these patients grow older, thermic tissue develop at an ectopic site other than the normal location. Autosomal recessive FOXN1 mutation have been described in small number of the patients who present with skin alopecia, hair loss, and nail dystrophy. FOX is the transcription factor for a forkhead family that is required for the development of thermic enlarge and other ectodermal structure. The node mouse, a strain that has been widely used in immunological research, lack thymus and hair because of mutation in some genes. Apart from defect in thermic enlarge, genes that record ingress of T cells from thermic can also cause SCID. A rare defect in the thymus has been described involving a mutation in conical A, which encodes for protein that regulate the actin cytoskeletons. The absence of functional cornea 1A results in defective ingress of the mature T cells from thymus. Homozygous mutation in MST1 genes, which encode for a certain threonine protein kinase, result in the failure of T cells to immigrate from thymus and loss of naive T cells in circulation. Patient presents with the recurrent bacterial and viral infection, and some develop Epstein-Barr virus-driven lymphocytes. Some patients present with the epidermodysplasia verruciformis, a disorder characterized by human papillomavirus-infected warts and skin carcinomas. MST1 play a diverse role in proliferation, cell survival, and cell migration. Although the major effect is immigration of T cell from thymus, there are also humoral immune defect in some patients who present with the domestic B cells, hypogammaglobulinemia, Bayer lymphocyte syndrome, and other defect in T cell positive selection. The generation of single positive CD4 and CD8 T cell from double positive thymocyte depend on the positive selection and lineage commitment events. Specific inherited mutation in genes can regulate the process of positive selection, abrogate the development of CD4 and CD8 T cells. Class 2 major histocompatibility complex deficiency called Bayer syndrome is a rare heterozygous group of autosomal recessive disease in which patient expresses a little of HLA, human leukocyte antigen, DP, HLA-DQ, and HLA-DR on the B lymphocytes, macrophage, and dendritic cell fail to express the class 2 MHC molecules in response to interferon gamma. They express normal or only slightly reduced level of class 1 MHC molecule. Most cases are the bare lymphocyte syndrome are due to mutation in genes encoding protein that regulate the class 2 MHC genes transcription. For example, mutation affecting constitutively expressed the transcription factor RFXF or the interferon gamma inducible transcription activation GITA leads to the reduced class 2 MHC expression. Failure of the antigens transplantation, failure of antigen presentation may reduce reduction in the number of mature CD4 T cells and defective activation of survived CD4 cells in peripheral. Affected individuals are deficient in delayed type hypersensitivity response in antibody response to T cell dependent protein antigens. The disease appeared within first year of life and usually fatal unless it is treated by hematopoietic stem cell transplantations. Autosomal recessive class 1 deficiency has also been described and are characterized by decreased CD8 T cell number and function. In some cases, the failure to express class 1 MHC molecules is due to mutation in the TAP and the TAP2 genes, TAP1 and TAP2 genes, which with antigen processing complex, TAP formally transport peptide from the cytosols into endoplasmic reticulum where they are loaded into the class 1 MHC molecules. Because empty MHC molecules are degraded intracellularly, the level of cell surface class MHC molecules are reduced in these TAP deficient patients, and phenotypically similar to TAP genes knockout mice. Such patients suffer mainly from necrosis, granulomatous skin lesion, and respiratory tract bacterial infection, but not viral infections, which is surprisingly considering that principal function of CD8 T cell is the defense against the viruses. A similar deficiency of class 1 MHC expressions has been observed in the patient with mutations in gene encoding for tapasin proteins, which is required for loading the peptide transported into endoplasmic reticulum and to nascent class 1 MHC molecule. Patients with ZAP7 deficiency have a lineage commitment defect resulting in reduced CD8 T cells, but normal number of CD4 T cells. The reasons for a selective loss is not clear. Although CD4 T cells development or immigration to the peripheral is not compromised, the cell fail to proliferate normally when challenged with the antigens. SCID caused by defective T cell activation. Another rare form of SCID is caused by mutation in genes encoding aura11 or aura11, a component of CRAC, calcium release activated calcium. In chapter 7, antigen recognition signal leads to the activation of gamma isoform of phospholipase and the isotyl triphosphate dependent release of calcium from endoplasmic reticulum and mitochondria. The released calcium is replaced by CRAC channel that facilitate the influx of extracellular calcium. This process is crucial for lymphocyte activation, and it is defective in cells with mutant ORAC2. A similar phenotype is observed in patients with mutation in STIM1, which encode for endoplasmic reticulum proteins that sense the depletion of calcium stored and contribute to the opening of crack channel. Patients with the ORAC2 ORI1 or STIM1 mutation do not exhibit defect in the T cell development, but T cell cannot be properly activated. Antibody deficiency, defect in B cell development and activation. Whereas defect in T cell development or in both T and B cell development cause SCID phenotype, more circumscribed defect in B cell result in disorder in which a primary abnormality in antibody production. Some of these disorders are caused by defect in B cell development, and other are caused by abnormal B cell activation and antibody synthesis. In one subset of hyper Igm syndrome discussed later, antibody deficiencies are also accompanied by defect in macrophage and antigen presenting activation, which is in turn result to defective cell-mediated immunity. X-linked agammaglobulinemia or an X-linked pre-B cells receptor signaling defect. X-linked agammaglobulinemia, also called Bruton's agammaglobulinemia, is caused by mutation or deletion in the gene encoding for enzyme called Bruton tyrosine kinase, BTK, resulting in failure of B cells to mature beyond the pre-B stage in the bone marrow. The disease is characterized by absence of antibody gamma globulin in the blood, as name implies. It is one of the most common congenital immunodeficiencies and prototype of the failure of B cell maturation. BTK, Bruton tyrosine kinase, involved in transducing signal from pre-B cells that are required for survival and differentiation of pre-B cells. If female carriers of this disease, if female carrier of this disease the only mature B cells are those that have inactivated the X chromosomes carrying the mutant allele. Patients with X-linked agammaglobulinemia usually have low or undetectable serum Ig, reduced or absence in peripheral blood and lymphoid tissue, no germinal center in lymph nodes, and no plasma cell in tissue. The maturation number and function of T cells are generally normal, although some of the studies have revealed reduced number of activated T cells in patients with which may be the consequence of reduced antigen presentation caused by lack of B cells. Autoimmune disorders such as arthritis develop in almost 20% patients. Whether this is related to the failure of self-tolerance or it is consequence of chronic infection caused by immunodeficiency has not been established. BTK, Bruton tyrosine kinase, is also involved in activation of myeloid cells, and susceptibility to infection, in addition to reflection of absence or near absence of antibody, will result in the partial BTK is also involved in the activation of myeloid and susceptibility to infection, in addition to reflecting absence or near absence of antibody, could also result in the part from defective immune function. The infection complication of X-linked agammaglobulinemia are greatly reduced by periodic, e.g. weeks or months, injection of IgG from healthy adult donors such as preparation form the antibody against common pathogen and provide effective passive immunity. Autosomal recessive form of agammaglobulinemia have been described, most of which can be linked to defect in the B cells receptor signaling. Mutant genes that have been identified in this context include genes encoding the mu, Igm, heavy chain, and gamma 5 surrogate light chain alpha, Ig alpha, a signaling component of B receptor and the B cell receptor. The P85 subunit of P1 kinase and blink adapter protein downstream for B cell receptor and B cell receptor. Selective immunoglobulin isotype deficiency. Many immunodeficiencies that selectively involve one or few Ig isotype have been described. The most common is selective IgA deficiency. This affects approximately 1 in 700 individuals Caucasian descent and thus the most common primary immunodeficiency in North America and Europe. Igm deficiency usually occur sporadically, but many families cases with either autosomal dominant or autosomal recessive pattern of inheritance are also known. Clinical features are variable. Many of people with IgA deficiency are normal. Others have occasional respiratory infections. They are rare, and rare patients have severe recurrent infection leading to permanent intestinal or airway damage associated with autoimmune disorder. The manifestation reflect of importance of secretory IgA protein of mucosa barrier from commensal and the pathogenic microbes. IgA deficiency is characterized by low serum IgA, usually less than 50, normally is 2 to 5 milligram per ml, with normal or elevated level of IgM and IgG and low IgA in mucosa secretion. The disease is genetically heterozygous, and in some patients, there is a defect in IgA class switching through the underlying basis of which defect has not been identified. In small proportion of patients with the selective IgA deficiency, mutation have been described in TAC, transmembrane activation, calcium modulator, and the cyclophilin ligands interactor. One of three types of receptor for cytokine, BAF, B cell lymphocyte factor, and April, a proliferative inducing ligands, and both of which stimulate B cell survival and proliferation. TAC mutation are also cause of commonly variable immunodeficiency, KID cause discussed later. So we have antibody deficiency, we have X-linked, function deficient, and mechanism. So X, this is decrease in serum Ig, isotype reducing B cell number. So mechanism here, the pre-B cell checkpoint defect, BTK mutation. Autosomal recessive form, decrease in serum Ig, isotype reduced, decrease in all cells serum Ig isotype, reduced B cell lymphocyte. So here the pre-B receptor checkpoint defect mutations in IgM heavy chains and surrogate light chains are seen. Hypogammaglobulinias, ISOP defect. This is selective IgA deficiency. Decrease in IgA may be associated with increased susceptibility to bacterial infections, protozoa such as Giardia. Mutation in TAC is in some patients. Selective IgG2 deficiency. This increased susceptibility to bacterial infections. Small subset have deletions in IgH2 locus. Common variable immunodeficiency. This is hypogammaglobulinemia, normal or decreased B cell number. So mutation in ICOS, TAC, CTLA4, and many other genes have been identified in some patients. Sorry. So other hyper-Igm syndromes is X-linked, defect in T helper cells, mediated B cells, macrophage and dendritic cell activation, defect in somatic mutation, class switching, and Gemino center for maturation, defect in cell-mediated immunity. These are X-linked. So here the mutation is in CD40 ligands. Autosomal recessive, X-linked autosomal recessive with cell-mediated immune defects. So defect of T cells, T cell-mediated B cells, macrophage and dendritic cells, activations, defect in somatic mutation, class switching, and Gemino center for formation, defect in cell-mediated immunity. Autosomal recessive with antibody defect only. Defect in somatic mutations and isotype switching, mutation in ID or other things. Selective IgG subclass deficiencies have been described in which total serum IgG level are normal, but concentration of one or more subclass are shown below normal. IgG deficiency is the most common subclass defect in the adult. Ig2 deficiencies are associated with reduced IgA in most common in children. Some individuals with these deficiencies have recurrent bacterial infection, but many do not have any clinical problem. Selective IgG subclass deficiencies are usually due to abnormal B cell differentiation and rarely homozygous deletion of virus constant region. Defect in B cell differentiation, common variable immunodeficiency, CVID. CVID is a group of heterogeneous disorder defined by reduced level of serum Ig, impaired antibody response to infection and vaccine, and increased incidence of infections. It is the most common immunodeficiency seen in adolescents and young adults. The diagnosis is usually one of exclusion when other primary immunodeficiency diseases are ruled out. The presentation and pathogenesis are, as the name implies, highly variable. The diagnosis is made based on very low serum IgG level, decreased IgM and IgA, a poor antibody response to vaccine with known genetic causes of hypogammaglobulinemia being ruled out. The prevalence in Caucasian population is estimated to be 1 in 10,000 and 1 in 50,000. Although Ig deficiency and associated pathogenic infection, typically with the Haemophilus influenza and Streptococcus pneumoniae, are the major features of this disorder. Autoimmune disease including pernicious anemia, hemolytic anemia, inflammatory bowel diseases, and rheumatic arthritis may be as significant clinically. A high incidence of malignant tumor, particularly lymphoma, is also associated with CVID. This disorder may be diagnosed early in childhood or late in life. The majority of the cases are sporadic, but from 5 to 25 of the patients have family history. Monogenic forms of CKID exhibit mainly autosomal dominant inheritance. Although some patients shows autosomal recessive inheritance, mature B lymphocytes are present, but memory B cells are typically reduced in the blood and plasma cells are absent in lymphoid tissue, which suggests a block in B cell differentiation. The defective antibody production have been attributed to multiple abnormalities, including intrinsic B cell defect or deficient T cells help. So this is just a diagram. You will have to read yourself. Monogenic causes account for approximately 10% of the cases of CVID. So far, mutation is over 25 different genes have been shown to be associated with the CVID. Mutation with TAC, described earlier in the context of selective IgA deficiency, have been described in some cases. Activating mutation with PIK3CD, the gene encoding the catalytic subunit of PIK3 kinase, lead to the hyperactive of T cells and the block in B cells development that result in CVID. Loss of function mutation in CTL result in defective function of regulatory T cells and poorly explained block in B cell development, which has caused CVID. A small proportion of patients with CVID have mutation in ICOS, inducible T cell costimulator. ICOS is required for T cell follicular helper T cells generations. Few cases of CVID has been linked to mutation in CD19 genes. CD19 is signaling component of CR2 co-receptor complex. Many other genes mutation have been identified in different CVID patients. Even in patients with whom the mutated gene is identified, the inheritance pattern is often more complex than usual Mendelian diseases. Defect in T cell dependent B cell activation, hyper-Igm syndrome. The X-linked hyper-Igm syndrome is caused by a mutation in the genes encoding the T cell effector molecule CD40 ligands, CD154. It is a rare disorder associated with the defective switching of B cell to IgG or IgA isotype. Production of these antibody is therefore reduced, and the major isotype detected in the blood is IgM. Production of high affinity antibodies is also impaired. Mutant forms of CD40 ligands produced in these patients fail to transduce signal through the CD40 and therefore do not stimulate B cells to undergo heavy chain isotype switching, which requires engagement of CD40 and B cells by CD40 ligands or helper T cells. Patients suffer suffer from an infection similar to those seen in other Ig deficiencies. Patients with X-linked hyper-IgM syndrome also show defective cell-mediated immunity with increased susceptibility to infection by intracellular fungi, microbes, and the P. girovec. This defect cell-mediated immunity occur because of CD40 ligands, and CD40 are also involved in T cell dependent activation of macrophage and dendritic cell. Knockout mice lacking the CD40 and CD40 ligands have phenotype similar to that of human disease. A small subset of cases of hyper-IgM syndrome shows autosomal recessive inheritance pattern. In these patients, the genetic defect may be CD40 ligands or in the enzyme activation induced diaminase, which is involved in heavy chain isotope switching and affinity maturation. A new rare form of hyper-IgM syndrome is caused by autosomal recessive mutation in the gene encoding uracil N-glycosylase, an enzyme that removes U residue from Ig genes during class switching and somatic mutations. An inherited disorder, ED, in which hypomorphic normal mutation contribute to a type IgM hyper-IgM state and defect in ectodermal structure is described earlier in the section on the defect in innate immunity. ID and UNG mutation affect class switching combination and somatic hypermutation in distinct way. In the absence of aid, both switching and hypermutation are defective because aid is required for both process. In the absence of UNG, isotope switching is defective, but somatic hypermutation is largely preserved. Although it exhibits less ATP mutation than normal, nevertheless, the largely shared phenotype of mutation affecting CD40 ligand, CD40 and the UNG link all these genes in one pathway of B cell activation, and an excellent example of how genetic disease inform our understanding of biological mechanism. Predictably, mutation affecting AIDS and the UNG affect B cells response, but unlike CD40 mutation, do not compromise cell-mediated immunity. Defect in T lymphocyte activation and function. Congenital abnormality in activation of T lymphocyte are being increasingly recognized in our understanding of molecular basis of lymphocyte activation the congenital abnormality in the activation of T cells lymphocytes are being increasingly recognized as our understanding of molecular basis of lymphocyte activation improves. Including in this broad category are some disorders such as CTL, cytotoxicity, lymphocyte, natural cells, general composition, and exocytosis. Although we classify disorder linked to defective MYC expression with the disorder of T cell development, these abnormalities also result in defective activation in T cell that do mature and emerge from thymus. Defect in T cell receptor signaling transduction. Many rare immunodeficiency diseases are caused by defect in expression of molecule required for T cell activation and function. Biochemical and molecular analysis of affected individual have revealed the mutation in gene encoding various T cell proteins. Examples include impaired T cell receptor complex expressions or function caused by mutation in CD3E and gamma genes, or defective T cell receptor mediated signaling caused by mutation in ZAP70. These defects are often found in only few isolated cases or in few families and the clinical features and the severity vary widely. Patients with this abnormality may have deficiency predominantly in T cells function and have mixed T cells and B immunodeficiency despite normal and even elevated number of blood lymphocytes. We have previously mentioned the impact of mutation affecting CD3 complex, the LCK and other proteins, and development of T cells like ZAP mutation on CD8 T cells development. The effect of LAC and UNC119 mutation on CD4 T cell development, and the relevance of ORI and the STEM mutation in T cell activation, all in the clinical context of SCID. Some other syndrome involving the defective activation of mature T cell are considered here. Hyper IgE syndrome. The hyper IgE syndrome, also known as Job syndrome, represents a collection of primary immunodeficiency syndrome in which patient have eczema, eosinophilia, recurrent pulmonary infection, and staphylococcal and fungal disease abscess, fungal skin abscess. The older the name Job syndrome was based on the biblical description, so went Satan forth from the presence of the Lord and smote Job with sore balls from the sole of his foot unto crown. One autosomal dominant form of hyper IgE syndrome results from heterozygous dominant negative mutation affecting STAT3, a transcription factor that is crucial for cell response of interleukin 6, interleukin 10, 17, 20, 22. Defective STAT signaling results in a diminished acute phase response downstream of interleukin 6, defective innate immunity, and defective T helper 17 response. And this likely results in a propensity of Staphylococcus aureus mediated cold abscess. The defect in STAT has many pleiotropic effects beyond the effect of T cell receptor cells, and also contribute to defect inhibitor response mediated by interleukin 10. Another autosomal recessive cause of HIES is mutation in the gene encoding DOCK8, a guanine nucleoside exchange factor. DOCK mutation results in reduced number of T cell and B cell, and NK cells, and defect in lymphocyte signaling and cytoskeletal rearrangement, resembling those seen in Wiskow-Aldrich syndrome. DOCK participate in pathway leading to ARP2/3 complex mediated actin of polymerization, and it is also required for maintenance of STAT3 phosphorylations. The name of this syndrome emphasizes increased level of IgE in the blood, and basis of this abnormality is likely linked to defective JAK-STAT signaling, leading to an increase in T follicular cell that make interleukin 4, interleukin 13, which drive IgE response. X-linked lymphoproliferative disease. X-linked lymphoproliferative disease, XLP, is a disorder characterized by an inability to eliminate Epstein-Barr virus, eventually leading to fulminant infectious mononucleosis and the development of B-cell lymphoma. It is in approximately 80% of cases, the disease is due to mutation in gene encoding an adapter molecule called SLAM, signaling lymphocytes activation molecule, associated protein SAP that bind to family of cell surface molecule involved in activation of natural killer cells T and B lymphocytes. SAP link the membrane protein SLAM and the 2B4 to CRC family kinase FN. Defect in SAP contribute to the attenuated natural killer cells and T cell activation, result in the increased susceptibility to viral infection, as discussed in chapter 12. SAP is required for T follicular cell development and the inability of XLP patient to produce germinocenter and high affinity antibodies also likely contribute to the associated hypogammaglobulinemia and susceptibility to viral infection. In approximately 20% of cases of XLP, the genetic defect resides not on SAP but in gene encoding XIAP, X-linked inhibitor of apoptosis. The resulting enhanced apoptosis of T cells and natural killer cells lead to marked depletion of these cell types. This immunodeficiency is most commonly manifested by severe opportunistic Epstein-Barr virus infection. So we have table 21.5, which is explain the defect in T cell activation. We have proximal T cell receptor signaling defect. Here, this is the disease. Then in the functional deficiencies, defect in cell-mediated immunity and T cell dependent humoral immunity. Mechanisms: the mutation in CD3 genes, CD45, STIM1, and ORI1. We have Wiskoff-Aldrich syndrome, autosomal recessive was-like disease, defect of T cell activations and leukocyte mobility, effective T cell activation and leukocyte mobility. So the mechanism here, T cell receptor dependent actin cytoskeletal rearrangement are defective because of mutation in WASP, or less often the WASP interacting protein genes. We have other like hyper IgE syndrome. Here, defective is T helper 17 and the interleukin 3 cells, innate lymphocyte cell 3, and mutation is the STAT and DOC8, STAT3 and DOC8. Familial hemophagocytic lymphohistiocytosis is X-linked lymphoproliferative disorder. This is uncontrolled Epstein-Barr-induced P cell proliferation, uncontrolled macrophage and CTL activation, defective natural killer cell and CTL. So here mutation in SAP, mutation in XIAP. X-linked immunodeficiency, magnesium defect Epstein-Barr virus infection, neoplasm syndrome. Here uncontrolled Epstein-Barr virus viremia and lymphoma. Mutation in MAGS. Perforin deficiency, uncontrolled macrophage of CTL activation, defective natural killer cell and CTL function. So mutation in perforins. We have granule function, uncontrolled macrophage and CTL activation, defective natural killer cells and CTL function, defective and cytotoxic granules, exocytosis mutation in RAB27A, Munich 13-4, syntaxin, AP, and Lex Cheriak Higash. You have seen already in the table. 21.2. X-linked immunodeficiency, magnesium defect, Epstein-Barr virus infection, neoplasm syndrome. The mutation is in the gene on the X chromosome encoding MAGIT, magnesium transporter proteins, 1, result in defect in natural killer cells and the cytotoxic T lymphocyte function, and also contribute to CD4 T cell lymphopenia. Patients have recurrent Epstein-Barr virus infection and other infection and lymphomas. This disorder is known as X-Men, X-linked immunodeficiency, magnesium defect, Epstein-Barr virus infection, neoplasm syndrome, intracellular level of free magnesium that are induced during T cell and NK activation. The marks contribute to the activation of gamma 1 in these cells and help to mediate subsequent calcium signaling. The cell signaling defect can be restored by supplementing the diet with magnesium. B cells, which have high level of different PLC isoforms, are infected by the absence of this transporter. This disorder highlights the role of magnesium in T cell activation. Defective CTL and natural killer cell functions. Familiar hemophagocytic lymphohistiocytosis. Familial hemophagocytic lymphocytosis syndrome are a group of life-threatening immunodeficiency disorder in which natural killer cell and cytotoxic T cell are defective in their ability to kill infected cells. As the result, viral infection are not held in neck, and compensatory excessive macrophage activation is feature of this syndrome. Because of this feature, another name of this disease is macrophage activation syndrome. A late but striking feature of this disorder is the ingestion of red blood cell by activated macrophage, hematophagocytosis. Mutation in perforin genes are the more common causes of familial HLH, but mutation in genes encoding the cellular machinery involved in granular exocytosis are found in some cases of syndrome. Specifically, mutation affecting RAB2527A, a small guanosine triphosphate involved in vesicular fusion, and the MUC13-4, an adapter that participates in granules exocytosis and compromise the fusion of lytic granules with the plasma membrane and thus contribute to various subtypes of HLH. Similarly, mutation in genes for one component of AP3 cytosol adapter proteins complex can also disrupt the intracellular transport and contribute to the form of HLH. It is thought that T cells and natural killer cells have defective cytotoxic activities and cannot clean intracellular infection, and the excessive compensatory interferon gamma mediated macrophage activation is manifested by hematophagocytosis and the lymphadenopathy in the context of immunodeficiency. An antibody that neutralizes interferons is approved for the treatment of familial macrophage activation syndrome. Multisystem disorder with immunodeficiency. Immunodeficiency is often one of constellation of symptoms in number of inherited disorder that affect multiple organs. Wiskoff-Aldrich syndrome. Wiskoff-Aldrich syndrome is X-linked disease characterized by eczema, thrombocytopenia, reduced blood platelets, susceptibility to bacterial infection. Some of the abnormality in this disorder can be traced in the defective T cell activation, although intrinsic loss of B cell function also contribute to the pathogenesis. The initial stage of the disease, lymphocyte number are normal, and principal defect is an inability to produce antibody in response to T cell independent polysaccharide antigens, because of which these patients are particularly susceptible to infection with encapsulated bacteria. The lymphocyte or platelets are smaller than normal. With increased age, the patients show reduced number of lymphocytes and more severe immunodeficiency. The gene that is mutated is Wiskoff-Aldrich syndrome, encoding the cytoplasmic protein called Wiskoff-Aldrich syndrome proteins, which is expressed exclusively in bone marrow-derived cells. WASP interacts with several proteins, including adapter molecules, downstreams of margin receptors such as GRB1 and the ARMP2/3 complex involved in actin polymerization, small g proteins of RHO family that regulate actin cytoskeletal rearrangement. Defective formations of immune synapse between T cells and antigen-presenting cell result in poor activation of lymphocyte and impaired mobility of all leukocytes may account for immunodeficiency observed in this syndrome. Autosomal recessive disease that resemble Wiskow-Aldrich syndrome has been described. This disease is caused by mutation in gene encoding WASP interacting proteins, a protein that bind WASP and stabilize it. Ataxia telangiectasia. Ataxia telangiectasia is an autosomal recessive disorder characterized by abnormal gait ataxia, vascular malformation telangiectasia, neurological deficiency, increased the incidence of tumor and immunodeficiency. The disease is caused by a mutation in gene that encode protein kinase called ATM, ataxia telangiectasia mutated. The immunological defects are of variable variety and may affect both B and T cells. The ataxia telangiectasia mutated is required for double-strand DNA strand break repair that is relevant to both VDJ recombinance and class switching recombination as described next. The most common humoral immune defect are IgA, IgG deficiency, probably because of the crucial roles of ITM in class switch recombination. The T cell defect, which are usually less pronounced, are associated with thermic hypoplasia. Patient experience upper and lower respiratory tract bacterial infection, multiple autoimmune phenomena, increase the frequency of cancer, and the advanced age. The ataxia telangiectasia mutated is related to the structure of PI3 kinase and activates cell checkpoint and apoptosis in response to double-stranded DNA breaks. It has been shown to contribute to the instability of double-stranded DNA break complex during VDJ recombinant. In ataxia telangiectasia, this abnormality of DNA repair accounting for abnormal generation of antigen receptor. In addition, ATM contribute to DNA stability when double-stranded DNA break are generated in the course of IG class switch combination, and the mutation of ITM result in defective class switching and reduce the level of IgA, IgE. Therapeutic approaches for primary immunodeficiencies. Treatment for immunodeficiency have two aims: to minimize, control infection, and to replace defective or absent component of immune system by antibody replacement or hematopoietic stem cell transplantation. Passive immunization with pooled gamma globulin is very beneficial for a gamma globulinemia patient and has been saving for many boys with X-linked agammaglobulinemia. Hematopoietic stem cell transplantation is currently treatment of choice for many primary immunodeficiency disease and have been successful in treatment of SCIDs, Wiskow-Aldrich syndrome, Bayer lymphocyte syndrome, and LAD. Enzyme replacement therapy for adenine deaminase deficiency is common treatment. Injection of bovine aid conjugated to polyethylene glycerol to prolong its serum half-life has proved successful in some cases, but benefits are usually short-lived. In theory, the ideal therapy for congenital disorder of lymphocytes is to replace defective gene in self-renewal stem cells. Gene replacement has proved successful for some disorder. The main obstacle for this type of gene therapy remains difficult in purifying self-renewing stem cells, which are the ideal target for introduction for replacing genes and introducing gene into cell to achieve stable, long-lived, and high-level expressions. Additional transplant recipients have been conditioned by depleted their bone marrow cell to allow transplant stem cells to engraft. And this carries a potential risk because of transient reduction of blood cell. Considerable progress has been made in gene therapy for other deficiencies and X-linked SCID for use of mild conditioned approach. Patients with X-linked SCID have been successfully treated with transplantation of autologous bone marrow cells engineered to express the normal gamma C genes. In L trials, small number of treated patients developed leukemia, apparently because introduced gamma C genes inserted adjacent to the oncogene and activated that genes. Development of newer self-activating lentiviral vector has reduced the risk of insertional mutagenesis, and this has led to the successful gene therapy for both ADA, SCID, and X-linked SCID. So the next thing that is going to be discussed is secondary acquired immunodeficiency. And as for now, I'll stop here first.